All right, so I'm going to provide ASH 2020 updates in myeloproliferative neoplasms.
Vivian, can you go to presentation mode?
Let's see.
I think you're good. You're good. You're good.
Am I good?
Yep.
All right. And these are my disclosures. And so the topics I'll cover today for overview are updates on interferon, updates for the JAK inhibitor momelotinib, and new therapeutic strategies for PV and MF that are under evaluation. So interferon revisited. We have earlier clinical studies of pegylated interferon alpha 2A. We know from prior work for a number of years that clinical hematologic response rates are between 79 to 100%. Complete responses are observed. Bone marrow histopathology may also revert to normal in some patients after interferon alpha therapy. That said, the mechanism is not fully understood. Questions that still remain in the field are hydrea and interferon equal in terms of response? Are there medium-term or longer-term benefits for interferon in terms of overall survival, leukemia-free survival, and myelofibrosis-free survival? And question mark, should we possibly consider earlier intervention for lower risk patients? So shown here is earlier data that was initially presented in 2018 from the MPD-RC study, which was a study of ET and PV patients with high risk, treatment naive. And the primary endpoint was the rate of complete hematologic response after 12 months of therapy. And what we know from this work is that there was no difference in hematologic complete response between the two treatment arms at 12 and 24 months. And this is for interferon alpha 2A, which I've highlighted there in yellow. So for the European study, PROUD-PV and its continuation study, this was a study of ropeg interferon alpha 2B. Now this was a study of early PV patients, not ET, so did not only have the high risk patients. For PROUD-PV, the endpoint was non-inferiority versus hydrea for complete hematologic response with normal spleen size at 12 months. And for the continuation study, the co-primary endpoints were CHR as well as improved disease burden. And so what was presented by Dr. Gieslinger at ASH this year were the efficacy data up to 60 months. Shown here are complete hematologic response up to 60 months. And this didn't turn out so well, but the top line there is the red ropeg interferon treated patients in red. And you can see, although hydrea looked a little bit better in the beginning for CHR, over time by 18 months, ropeg interferon was better with over 70% of patients achieving a complete hematologic response, and this was highly statistically significant. Additionally, if we look at JAK2 allele burden, it was only with ropeg interferon that we saw a decrease in the allelic burden of disease, and this also was highly statistically significant. A presentation that I won't go over today also talked about being able to discontinue therapy in patients and still maintain a complete hematologic remission, which might be a strategy to mitigate adverse events. With regard to the other question, does interferon alpha have an impact on myelofibrosis-free and overall survival? Dr. Abu Zena presented data from Weill Cornell Medical Center. And so this was a single center retrospective study from Weill Cornell of 470 PV patients between 1966 to 2019. Among this group, 133 patients were treated with phlebotomy only, 93 with interferon, and 189 with hydroxyurea. As you can see, I've shown in the boxes, the median age of the interferon treated was a little bit lower. Additionally, the cardiovascular risks were lower in this group, and with regard to ELN risk, which is driven by age and thrombosis in this population, this was also lower. What they reported in this study, although I will point out as time goes on, there are a lot fewer patients for this analysis, is that there was improved overall survival in interferon alpha treated patients with high risk, shown here in red, but no statistically significant difference was shown for the lower risk. In terms of myelofibrosis-free survival, in the low-risk patients, we do see a benefit for interferon. In multivariable analysis of this study for patient with regard to reduced MF, only time on interferon therapy was statistically significant. In their analysis, this translated into about a 9% MF risk reduction per year on interferon. With regard to overall survival, age, sex, as well as time on interferon were statistically significant, and this turned out to be a 6% mortality risk reduction per year on interferon. I'm now going to talk about some new therapeutic strategies in PV, and this was an abstract of PTG300 presented by Dr. Kremyanskaya from Mount Sinai, which was highly anticipated. And so PTG300 is a hepcidin mimic. And so in PV patients, we know that iron deficiency as well as expanded erythropoiesis contribute to low hepcidin. And so in this state, as shown at left, ferroportin remains open, allowing iron to be available for erythropoiesis. In the presence of this hepcidin mimetic PTG300, ferroportin is closed, iron efflux does not occur, and this ultimately reduces erythrocytosis. For this phase 2 study of PTG300, the eligibility criteria were PV patients needing 3 or more phlebotomies within a 6-month period. The primary endpoint was the proportion of patients randomized in the randomized withdrawal period whose hematocrit was maintained without the need for phlebotomy. This is the clinical trial design. There was a dose-finding phase as well as an efficacy evaluation phase. This was followed by a randomized withdrawal phase, and then an open-label extension phase is to follow. So far, 18 patients have been dosed. As is shown here, those red circles are phlebotomy. And so what you see at the left is the numbers of phlebotomies needed in these 18 patients prior to dosing. And what you see here in that purplish pink color is PTG, and you see only 3 red dots there. And so there was a very significant decrease in the need for phlebotomy after PTG 300 was initiated. Shown here is a hematocrit response, and you can see after 16 weeks, this becomes statistically significant. And there was no impact on white blood cell count and platelets with this agent. So another abstract I'd like to present is just a revisit of what causes mortality and death in patients with polycythemia vera. And so this was a prospective study entitled REVEAL, and this was presented by Dr. Brady Stein. And I have to admit, you have to really struggle with the acronym here, so I've highlighted it in red as to how it actually came together. But this was a study of 227 community and academic practices in the US. These were patients enrolled from July 2014 to August 2016, and there were 2,510 patients prospectively enrolled. We can see generally, so the purpose of this analysis was to compare patients who died, 244, versus those who are still alive, 2,266. And generally compared to patients who were alive, significantly more patients died during the study, were characterized as high risk of diagnosis, and this was driven predominantly by age. And so what were the causes of death? Well, of patients with known cause of death, the most common cause was vascular complications. So this is probably not new information. We know that the primary cause of death for polycythemia vera patients are actually arterial vascular events, such as MI, stroke, and others. They also found that respiratory failure was reported as a cause of death in 13.1% of patients. This was not fully elucidated and needs further investigation. Death due to disease or progression was seen in 15.4% of patients, infection in 10.3%, and bleeding in 6.3%. I'm going to now turn to updates for other JAK inhibitors in myelofibrosis, and this was presented by Dr. Verstovsek, and these were data for momelotinib. So we know that momelotinib is a JAK1, JAK2 inhibitor, but what is unique about momelotinib is that it's also an inhibitor of ACVR1. And when this is inhibited, this results in decreased hepcidin, increased iron availability, and increased erythropoiesis. What we know from other studies is that in Simplify-1 and Simplify-2, Simplify-1 was the JAK inhibitor naive study, Simplify-2 was the JAK inhibitor resistant or intolerant study, that momelotinib provides splenic responses versus ruxolitinib, improves constitutional symptoms, and also improves transfusion burden and anemia. And the data here we can see for Simplify-1, which is frontline. The top line there in blue are our momelotinib treated patients, where we can see hemoglobin levels preserved. The gray line is ruxolitinib treated patients. You can see the decrease in hemoglobin, then increasing once a crossover occurred. Also, similar findings were seen for platelet counts. And so ultimately on momelotinib and Simplify-1, dose intensity could be preserved better. So in this analysis, as presented, landmark transfusion independent rates for Simplify-1 were 67% in momelotinib treated patients versus 49% of ruxolitinib treated patients. And with more than 3 years follow-up, the median duration of transfusion independence has not been reached. Similar data were seen for Simplify-2, although of course at a lower rate, and the landmark transfusion independent rate at 24 weeks is 43% in momelotinib treated patients versus 21% in those with best available care or ruxolitinib. What was an interesting observation, because we know that patients who fail ruxolitinib typically have poor overall survival outcomes, was that the median overall survival in the original group of momelotinib treated patients or those who crossed over was actually reasonably good at 34.3% and 37.5%. And so what we have ongoing now is the phase 3 randomized double-blind study of patients previously treated with JAK-I inhibitor, randomizing patients to momelotinib versus the erythropoiesis stimulating agent danazol. Also want to do a quick plug. I have discussed data for pacritinib at an earlier update from ASCO earlier this year. But for patients with severe thrombocytopenia, either first or second line myelofibrosis patients, we are enrolling at SCCA for the Pacifica study, which is a randomized study of pacritinib versus physician's choice. So ultimately, in a slide I borrowed from Dr. John Mascarenhas, in the future, we may have more rational decision-making that we can make for JAK inhibitor selection for our thrombocytopenic patients with less than 50,000 platelets pacritinib. For our red blood cell transfusion-dependent patients, momelotinib may be a better choice. In the last part of my talk here, I'm going to review some of the new treatment strategies, not all that were presented at ASH. And so what we saw at this meeting in those sessions were updates for the BCL-XL, BCL2 inhibitor, navitoclax, updates for MDM2-p53 interaction inhibitor, idasanutlin. I won't present these data, and the study has been terminated. With regard to epigenetic targets, we had updates for BET inhibitors and LSD1 inhibitors, and Metelstat, the telomerase inhibitor, has been revisited, and I'll present these data. And lastly, I've presented data on luspatercept as presented by Dr. Aaron Gerds. Earlier, I'll give a quick update on clinical trials coming out of that. So Dr. Pemaraju presented on the addition of navitoclax to ruxolitinib in patients with relapsed refractory myelofibrosis. And so navitoclax is a novel orally available inhibitor of BCL-XL and BCL2, anti-apoptotic members of the BCL2 family. In preclinical studies, we have seen that the combination of JAK2 and BCL2, BCL-XL inhibition can enhance malignant cell death over JAK2 inhibition alone. And a phase 2 study in patients with myelofibrosis has previously reported clinical responses after treatment with navitoclax and ruxolitinib in patients who no longer benefited from ruxolitinib. So the study design for this phase 2 single-arm open-label study is shown here. The endpoints are our typical endpoints: percentage of spleen volume reduction at week 24, percentage change from baseline to week 24 in the total symptom score. Additionally, there were exploratory biomarker studies as well. And so what Dr. Pemaraju showed was that among the 34 patients treated, that 27% of these patients achieved a spleen volume response of greater than or equal to 35%, and among 30%, a TSS reduction of greater than or equal to 50% was seen. Additionally, among 46% of patients, a reduction in variant allele fraction was seen in 10% or more, and the waterfall plots are shown below. These improvements were independent of the presence of HMR mutations or high numbers of total gene mutations at baseline, and the preliminary results suggest that a combination may modulate key cytokines that have previously been implicated in total symptom score improvement. And so what's now just opened are a randomized phase 3 study of navitoclax plus ruxolitinib in relapse refractory MF, and then also a frontline study in JAK inhibitor naive patients, Transform-1. Dr. John Mascarenhas presented updates for CPI 0610, which is a bromodomain extra-terminal domain protein inhibitor in combination with ruxolitinib, and he presented the JAK inhibitor naive patients from the Manifest phase 2 study. And so BET inhibitors, CPI 0610 is a BET inhibitor, and ultimately the result of BET inhibition is a suppression in cytokine production. It promotes erythrocyte differentiation and also normalizes megakaryocyte differentiation. And so far, 78 patients have been enrolled in this particular arm. So we know from earlier presentations of this agent that the most interesting results that we've seen is when you combine this agent with ruxolitinib. Primary endpoints, again, for this study were transfusion and spleen response. And so Dr. Mascarenhas here at this ASH meeting presented results of arm 3 in the JAK inhibitor naive patients. And so as shown by these waterfall plots here, we saw a spleen volume response reduction 35% in 67% of patients, 72% of intermediate 1, 64% of intermediate 2 or higher. With regard to hemoglobin improvements, this was most evident, shown here in the orange, in patients who had a hemoglobin less than 10 grams per deciliter. There's also a signal that there was an improvement in bone marrow fibrosis, with 33% of patients having at least 1 grade improvement in bone marrow fibrosis. And so based on this, a phase 3 randomized double-blind trial of this agent with ruxolitinib versus placebo plus ruxolitinib in JAK inhibitor naive patient population has been initiated and is now open for enrollment. Also presented at this meeting by Dr. Kristen Pettit were early updates for the phase 2 study of the LSD inhibitor IMG 7289, which is also available at the SCCA in clinical trial in patients with advanced myelofibrosis. And so the rationale for targeting LSD1 in MPNs is as followed. So LSD1 demethylates H3K4 and other chromatin-associated proteins, including P53. It's overexpressed in MPNs. The loss of LSD1 activity is associated with the loss of clonogenic potential in malignant HSCs, and LSD1 inhibition impairs function of both activated megakaryocytes and malignant stem cells. In this study, the primary endpoints for this early study is safety and tolerability, as well as PK. The key eligibility criteria, because this agent does cause thrombocytopenia, is that patients had to have platelets greater than or equal to 100,000, and then each patient had a dose titrated specifically to platelet count. And so with evaluable patients in terms of 78% of these patients had a decrease in the total symptom score, and among spleen volume responses in the phase 2 portion of this study, 14 evaluable, 86% had some decrease in spleen volume, and 14% had greater than or equal to 35%. There are similar studies of this agent ongoing in the treatment of essential thrombocythemia and polycythemia vera, and the ET study actually has just been opened by Dr. Anna Halperin at the SCCA. And a combination of this agent plus ruxolitinib will begin next year. So I'm also going to present data from imetelstat, which has been presented for a number of years, but now is being revisited with these data by Dr. John Mascarenhas. So imetelstat is an oligonucleotide that specifically targets the RNA template of human telomerase. So short telomere length, high levels of telomerase activity, and high expression of hTERT correlate with higher risk, disease progression, and shorter overall survival in patients with myeloid malignancies. And preclinical studies have demonstrated that imetelstat reduces telomerase activity, hTERT expression level, and numbers of JAK2 V617F positive hematopoietic progenitor cells in MF patients. And so the EMBARK study was a randomized, single-blinded phase 2 study of imetelstat in resistant and intolerant intermediate 2 and high-risk MF patients, and it evaluated 2 doses of imetelstat, 9.4 milligrams per kilogram and 4.7 milligrams per kilogram. There was a dose-related clinical benefit at the higher dose in terms of symptom response and improvement in overall survival. And so this study had a very unique primary endpoint in our field, which is an overall survival endpoint. So this was actually the primary endpoint, as well as spleen response and symptom response and fibrosis improvement. And what's shown here in blue, which is the higher dose of the 9.4 milligrams per kilogram, is a possible overall survival benefit at this dose in patients with MF that is refractory or intolerant to JAK inhibitor. This overall survival, so pretreatment dips, high risk, ECOG performance status, transfusion dependency, response to your last JAK inhibitor, as well as lower baseline hemoglobin and platelet values correlated with increased risk of death. Also, lower risk of death significantly correlated with improved bone marrow fibrosis in patients treated with imetelstat. So based on these data, the phase 3 IMPACT MF study of imetelstat in patients with refractory myelofibrosis with a primary endpoint of overall survival is expected to open for screening and enrollment in Q1 of 2021. So quickly for luspatercept, which I presented previously from Aaron Gertz. So luspatercept is a first-in-class erythroid maturation agent that binds to several TGF-beta superfamily ligands to diminish SMAD2/3 signaling and enhance late-stage erythropoiesis. It's approved by the FDA for beta thalassemia and transfusion-dependent very low and intermediate risk MDS with ring sideroblasts or MDS-MPN-RST. So a phase 2 study in MF has indicated that cohorts who received a stable dose of ruxolitinib, these were the cohorts 3A and 3B in the study, experienced better responses. And Dr. Gertz has presented this on several occasions. Based on these promising data, a phase 3 randomized placebo-controlled study examining the safety of luspatercept compared with placebo in patients with MPN-associated myelofibrosis on concomitant JAK2 inhibitor therapy and require blood cell transfusions is planned. And I think this will be an important new agent for us, hopefully in the future. I'm going to end with probably my favorite abstract presented by Dr. Nangalia. So I really suggest you tune into this abstract. And so at the end of the day, what she presented in a very elegant mathematical modeling study using primary patient samples is that JAK2, including and DMT3A and possibly other mutations, are actually acquired very early in life in utero and childhood, and that there are variable rates of clonal expansion, and that sequential driver mutation acquisition is separated by decades of rapid growth, and the expansion rates determine the latency to diagnosis. Thus, mutation detection and rates of expansion could enable preventative strategies in the future. So please take a look at that particular abstract. So my take-home points, ASH 2020, consider interferon. There is a possible future with rational selection among JAK inhibitors based on patient comorbidities and the presence of severe anemia and thrombocytopenia. And there are combination strategies with ruxolitinib that look promising, and phase 3 studies are opening. I'll end with a shout out to Dr. Anna Halpern and Dr. Bart Scott, who see MPN patients with me over at the SCCA. There at the left are our list of MPN studies, also a few for CML as well too. So we've got Pacifica for pacritinib. We've got an agent which I didn't talk about today, 9-ING41, a glycogen synthetase kinase 3 inhibitor in myelofibrosis. We also have the LSD inhibitor Imago study, IMG7289 for MF. The CARTOS study for the MDM2 inhibitor, also post-PV, post-ETMF. And just opened is the Imago 7289 in ET patients by Dr. Anna Halpern. And then lastly, a phase 2 trial of decitabine in combination with JAK inhibitor as a bridge to transplant in patients with accelerated blast phase myeloproliferative neoplasms. And thank you so much today for your attention, and thank you again for the invitation to speak today.
Vivian, thank you very much for your great presentation, a lot of information, a lot of clinical trials to consider.